Morning everyone. As far as systemic workup of a vascular occlusion case is concerned, there is a list of investigations which is available in all textbooks. Let us not be very theoretical about it. Let us consider practical aspects as to where what is required, and we'll be able to narrow down to only very specific investigations. Now, as retinal surgeons or general ophthalmologists, we are as ignorant about the systemic workup of a patient, of any patient concerned with having an ocular disease. So let us try to understand as such how we can best work up a patient so as to be able to advise the actual specific test. Now, no systemic workup is actually possible without knowing the pathophysiology behind a vascular occlusion. Now, it begins with this very important essential question, whether what you see in this retina, as the arrow is pointing out, is this one is an artery or an arteriole. Now, we all know that the artery, ophthalmic artery, ends over here, which gives rise to what we call as a branch retinal artery, which in the true sense is not an artery, it is an arteriole. Now, why we need to know this is because the arteriole then divides on further into first, second and the third order arterioles. At the foveal, in the foveal area, it forms a capillary network and then forms venules again to form the ophthalmic vein. So, when you have an artery, the diseases are different as compared to an arteriole. Now, why so? Because in an artery, the coat adventitial is common with the small vessel. The middle one is mainly having elastic tissue as against muscular collagen, which is there in the arterioles. So whenever you have a disease of any large vessel, the occlusion has to be always from within, because when you have an inflammation of the wall, it may not be sufficient so as to occlude the lumen being large. In any medium-sized or a small vessel disease, the pathology is usually within the vessel wall, in the muscular collagen, typically what we call as collagen vascular diseases, where there is deposition of either fibrinoid material, hyaline material or a cellular reaction, as against the luminal deposition of either a thrombus or a cholesterol plaque from which emboli emanate. So when you have a large vessel, primarily we need to know that the occlusion is from within, either by a thrombus or by an atheromatous plaque which may throw emboli. And as far as an arteriole, venule or a small vessel is concerned, the occlusion is always from without or from the wall, which is mainly by way of vasculitis or by arteriosclerosis. Now, this is to be differentiated from atherosclerosis, which is predominantly fat deposition. Arteriosclerosis is hyaline and calcium changes which are age related, related to thickening of the vessel wall because of increased resistance. Any large vessel disease, when you have occlusion from within, it usually causes just occlusion. A small vessel disease, when you have anything involving the wall, it destroys the endothelium. You can have occlusive symptoms as well as leakage symptoms. So when you divided any vascular occlusion into large and small vessel, a large vessel, as I said, occlusion within, thrombus and atheromatous plaque, you have these diseases, CRAO, ocular ischemic syndrome, CRVO, and venous stasis retinopathy, which is nothing but the OIS equivalent of a central retinal vein occlusion. When we come to small vessel, inflammation or vasculitis involving either the venule predominantly, you have TB, sarcoid, syphilis, HIV, arteriole predominantly you have SLE, PN, vaginous. Now this is a slight simplification because there is an overlap from the arteriole onto the venule side and from the venule to the arteriole side. As far as arteriosclerosis is concerned, you have diabetes mellitus, BRVO and so on. So now, as I said, when you have any large vessel disease, the pathology is mainly confined to the periphery of retina, which is also called the watershed region. You may have hemorrhages, cotton wool spots and capillary dropouts because the disease is primarily occlusive in nature. Even when you have neovascularization, you have it either at the iris or at the angle, as what we see in cases of ocular ischemic syndrome or CRVO. As far as small vessel diseases are concerned, it is mainly leakage as well as occlusion. So in addition to hemorrhages, cotton wool spots and dropouts, which are primarily occlusive components, there is leakage of hard exudates as well. Now this foveal avascular zone, which is usually enlarged in vascular occlusions, is not enlarged because it is a watershed region. It is simply enlarged because of the occlusion of these small vessels. So when you predominantly have vasculitic pathology involving either the arterioles or the venules, now how can you really differentiate the two based on a clinical picture? Arterioles have usually paucicellular or poor cellular reaction as against venule, which have polycellular reaction. So in a venular pathology, you will always have a little bit of vitritis or paravenous exudates as is shown in the picture, as against predominantly arteriolar disease where you have microaneurysms, dot plot hemorrhages, hard exudates and cotton wool spots. Now can you have a vasculitic pathology in a large vessel and similarly reverse a atheromatous or embolic picture in a small vessel? As I said, the vessel wall, even if inflamed, is not sufficient to actually occlude. So vasculitic pathology of large vessels are less common. Also similarly, embolic pathologies of small vessels are less common. All the same, we need to know them if we have to consider investigating those diseases. As I said, the large vessel is occluded only from within, small vessel occluded from without. But when you have a reversal of pathology, you see that there is vasculitic changes in the vessel wall causing a thrombus formation and occlusion, as well as emboli in the arterioles. Now which are those diseases? When you have large vessel vasculitis, cell arteritis as happens in old patients, or Takasayu's arteritis as happens in young. When you have an embolic pathology in a small vessel, you have usually the smaller emboli occluding these arterioles, which is either seen in Putsch's retinopathy or endocarditis forming Roth spots. So when you have this classification handy with you, you really easily know how to investigate these patients. So when you predominantly have an atheromatous disease, it is either ocular ischemic syndrome or central retinal artery occlusion, the investigations of which are nearly the same. Now, in these investigations, I would like to specifically highlight how would you actually study a carotid stenotic picture, which is actually very commonly associated with CRAO and OIS. As far as a thrombotic pathology with a central retinal vein occlusion is concerned, we need to know all the hyperthrombotic states starting from hyperhomocystinemia, antiphospholipid antibody, protein C, protein S, and then hyperviscosity syndrome. I may touch upon the specifics of a few investigations rather than going through all of them. As far as vasculitis or small vessel disease is concerned, when you know that it is involving predominantly the arterioles or venules or only the posterior pole, these investigations are usually sufficient. And anti-nuclear antibody, dsDNA, P-ANCA, C-ANCA as happens in PN and Wegener's, ESR and CRP. As far as TB sarcoid is concerned, we have those specific investigations including VDRL and TPHA. When you have arteriosclerosis involving the smaller vessels, the predominant pathology is hypertension followed by diabetes and hyperlipidemia, which just speaks of a gross metabolic derangement. Now, amongst these investigations that are used for carotid stenosis, ultrasound, digital subtraction angiography, MR angiography and CT angiography, what is actually relevant to us is just a USG report. In the USG report, they do what they call typically as a duple USG, in which you have a B scan which shows how thick the obstruction is in the internal carotid and how the flow characteristics are, which is shown by the Doppler. Now this is the most important slide in order to know or interpret USG. We are all aware of Bernoulli's principle, wherein a liquid is flowing through a vessel. If you get a sudden obstruction, the velocity suddenly is. Why? Because the same volume of blood has to pass on to this side, meaning in a thinner lumen it has to go faster. So when we have this velocity in the obstructed area, it would be the fastest as compared to the proximal and the distal area. As also this is associated with drop in pressure. So the moment you go on to the distal side, the velocity becomes really slow and the pressure drops. So you have these typical velocities that are there in the vessels. In the occluded vessel, the velocity is the largest, is the biggest. Now this is very important for us in interpreting a report. Contrary to what we feel, when you have the highest velocity, which is peak systolic velocity, the blockage is the maximum. Now you see this over here, this speaks about peak systolic velocity on the Doppler. The higher it goes, the bigger the blockage is. This is typically a 70 to 90% blockage because it is showing a peak systolic velocity of 160 centimeters per second. Now this is showing a plaque in the internal carotid. Now contrary to this, or exact reverse of this, is when you do a USG Doppler of the ophthalmic artery. Now because I said distal to the obstruction, the velocity reduces, the peak systolic velocity is low when there is obstruction of the ICA, as in when you do a USG of the carotid, there is increase in the peak flow velocity when there is increased obstruction of the ICA. So this you see very typically the velocities go down in the ophthalmic artery. You see a dicrotic notch in systolic velocity. In fact, in this picture over here, you see a negative flow. It has gone so low that it has reversed in the diastolic phase, which is typically called flow reversal. Now flow reversal can be easily described by this schematic diagram. When you have an obstruction of the internal carotid artery over here, from the external carotid via the circle of Willis, you can have blood flow into the ophthalmic artery, which is a normal anterograde blood flow. However, if there is an obstruction of the internal carotid artery here, from the orbital vessels over here, you can have a reversal of flow if the pressure in the external carotid circle of Willis is not sufficient so as to cause an ophthalmic artery circulation. Coming to CRVO investigations, I'll highlight upon the first one, hyperhomocystinemia. Now, the clinical importance of this investigation is that very often we find that serum homocysteine is normal and yet the patient has a tendency for CRVO. Now why so? It is very essential to understand the pathway by which homocysteine is formed from methionine. So let us not go into the details of this pathway, just concentrate on these three enzymes: methylene tetrahydrofolate reductase, methionine synthase and cystathionine synthase as underlined in red. All these require cofactors of B6, folic acid, B12 and B6, which is pyridoxine. Now any derangement of these enzymes results in the accumulation of homocysteine and its subsequent conversion into cysteine. So when you have a high homocysteine, obviously you may have a tendency for CRVO, but when you have a normal homocysteine also you can have a tendency for CRVO, simply because when you have a normal homocysteine, you can have a correspondingly high cysteine. Now if you have the enzyme only deranged in these two places, all your homocysteine will actually get converted into cysteine and you may actually have a high cysteine level. Conversely, you can have a high homocysteine with a normal cysteine level. So either one has to be high, and when one is investigating, it is not just to find out homocysteine levels, cysteine levels also have to be done concurrently. As far as antithrombin 3, protein C and protein S investigations are concerned, the important highlight in this slide is that there are two types of defects. One is quantitative and the other is qualitative. So when I say that there is a decreased functional activity of antithrombin 3, protein C, protein S, they could still be having normal levels because the quantities may be the same in type 2, but there is a decrease in the quality or decrease in the actual molecule. There may be a molecular modification so that you may have the similar molecule, but there may be a few changes in amino acids. The quantity remains the same, the quality of it delivering the effect reduces. Thank you.